Sorry.
Can you see my
Yeah.
screen? Okay. So let's continue. We finished metabolism the last time. So today we can start a new topic. We said either musculoskeletal, neurology, psychiatry, maybe reproductive, respiratory, leave it for later. So you have to choose one. Choose one.
Oh, I thought we're doing farm. No.
It's possible to do farm, but basically, I hate doing two difficult subjects with the student like one after the other, because you
Yeah.
just becomes kind of depressed, because it's like something difficult like metabolism, and then something difficult like pharmacology, and you are like, come on, seriously?
Okay. Yeah, give me the easy one.
Give me the easy one. I like that. Okay, so here is the thing. There is nothing easy in life, but if we say, well, musculoskeletal has a little bit of memorization, but it's easy, but a lot of memorization. Neurology has both memorization and it's a bit difficult. Psychiatry is super easy. And reproductive is moderate, not easy, not difficult. Respiratory is moderate as well. So you decide.
Okay. I don't know. Maybe neuro. No.
Well, we can start with something that has some memorization. The reason being that you will have to memorize this. So you will memorize this now and then you will forget it. And then you will memorize
Okay.
it again and then you will forget it. And then when you memorize it the third time, it will just become more easy to memorize. And then you will forget it. Okay?
All right.
Good. So let's do it. Okay, so we are going to start the musculoskeletal system. The idea here, we are going to start to speak about anatomy. In the USMLE, they truly love the basically the shoulder blade. Okay, so in the shoulder, basically, as you can see,
You're recording, right?
yes,
Thank you.
our shoulder consists of multiple bones connecting together, mainly the scapula and the humerus, correct? And they want you to know how the movement happens in it. I mean, what does it mean when I raise my arm, when I put it down, when I abducted? What does abduction even mean? So, in this class, today class, I'm going just to give an introduction. Basically, you are going to get the directions again, and what do they mean, and the planes and different planes, and what do they mean as well, and yeah, stuff like this. So let's start with anterior posterior. What you know what that means, right? You know what is anterior posterior mean?
Yeah.
Okay, do you know what is ventral and dorsal mean?
Not really.
Okay, so
Okay.
ventral is the same as anterior. Dorsal is the same as posterior. Okay? So these are important words. I am going to give it to you because if you don't know this stuff, you will get lost. So as you can see here, anterior is ventral. Posterior is dorsal. Correct? Cranial is towards the head. Caudal is towards the tail, but we don't have tail, correct? So we call the butt area basically the tail, okay? So that's caudal. Okay, when they say something is superior, it's like on the upper portion, inferior at the lower portion, correct? When something is proximal to the body, it means it's more close to the body. So our shoulder is proximal to our trunk, while our hand is distal to our trunk, correct? So proximal mean nearby, distal mean far away, correct? If you draw a midline here, when I say I'm going medially, it means I'm going towards the midline. But when I'm going laterally, I'm going away from the midline, correct? Okay. So the next thing that I want you to know is what is an anatomical, where are you? An anatomical position. Do you know what that means?
So follow this rule, right?
Again?
Follow this picture. Is it the same thing?
Actually not this one, but this one. You are like, it's exactly the same. No. Look, this lady putting her hand on her side. This is wrong. In anatomical position, we imagine the body to be laying on her back while the palms are open to the front. Okay? That's the correct anatomical position. Okay, you are like, but that's stupid, does not make sense. No, it's important. I will tell you why. Because if you say the medial portion of the arm and you look at it like this, you might be thinking about the thumb, correct?
Mm-hmm.
Which is wrong. But if you look at this picture with the correct anatomical position, and I tell you the medial portion of the arm, of the hand, you think about the pinky, which is correct, right?
Mm-hmm.
So always know the anatomical position and what goes with it. Only open palms facing forward, that's it. So, okay, now you know what is anterior, posterior, ventral, dorsal, superior, inferior?
Yeah.
Caudal and cranial as well. You know all of these, correct?
Mm-hmm.
So now time to speak about what does plane mean. A plane is basically a topographical area that you cannot see in your eyes, okay?
Mm-hmm.
So basically when they show you a CT scan, they tell you we took it in a transverse plane. Transverse plane means this. As you can see, it's a cut, correct?
Mm-hmm.
Or they can tell you it was in the sagittal plane, as you can see this one, right? It means like it cuts in half, right?
Mm-hmm.
Or it could be also something called the frontal plane, which is this. Frontal plane has another name. They also call it coronal plane, okay?
Mm-hmm.
Wanna see something cool?
Yeah.
So if you take a look at the cranium sutures, like you know, our skull sutures, one of them is called the coronal suture. So it's like the coronal plane, correct?
Mm-hmm.
Also, we have the sagittal suture, as you can see here, which is the sagittal plane, correct?
Mm-hmm.
Make sense?
Yeah.
Okay, so we have the coronal plane, which is also known as frontal plane, correct?
Uh-huh.
We have the sagittal plane and we have the transverse plane. This is all of the planes you have to know about. Everything makes sense so far?
Yeah.
Good. I hope you are annotating everything because I know it's a lot. So let me just send you this. So the next thing I'm going to speak about is what the hell is abduction and what is the hell is adduction. So, okay, look at the word abduction and adduction. Here the B and the D are like two, they are facing each other, correct?
Mm-hmm.
So they are going opposite side from each other. So they go far away from each other. While the D and the D are the exact same, so they are going towards each other. So what I'm trying to say, that a deduction, because it's a D and a D, they go towards each other. But a B and a D, they go away from each other. Got it?
Mm-hmm.
Good. So this is a deduction and abduction. Make sense?
Yeah.
Nice. The next one. So let's speak about something called supination and pronation. Okay, so one moment. Okay, good. So let's take a look. A deduction, abduction makes sense, correct?
Mm-hmm.
Keep in mind, however, the arms is in this degree, like it's straight outward, right? Just like this.
Yep.
Because if you raise it just forward, this is called something else, okay?
Mm-hmm.
Okay, so we spoke about adduction and abduction. Let me now tell you about internal and external rotation. Internal rotation, it's when you get your arm here, and you put it forward towards your body. You just rotate it forward in a circular motion. Okay? But when you do it in an, well, outside motion, we call it external rotation. All make sense?
Yeah.
Okay. We also have extension and deflection. The general idea about the word extension, it's to put the organ away from the trunk, okay? Anything that moves the organ away from the trunk, we call it extension. For example, when I extend my knee, I'm basically flattening my leg, correct? Why? Because you just put it away from your trunk. So that's extension, correct? So flexion, on the other hand, it's when you bring something close to your body, as to your trunk, correct? So, okay. So let's take a look here. The next thing is going to be as follows. So you can see flexion, extension, and you can see external rotation, internal rotation, and we also have abduction and adduction. Okay, the next one is going to be pronation and supination. Pronation is when you imagine the anatomical position again. So now we are speaking only about the palm, okay? The palm, the arm, the hand. So when you put it inward, this is called the pronation. Pronation is basically the internal rotation of the palm, okay? So when you speak about the palm, we don't say internal rotation, instead we just say pronation. So you pronate inward, supinate outward, okay? All make sense?
Yeah.
Okay, good. So flexion of your hand, it's when you make a fist, basically. Extension is when you make it flat. Got it? Okay, if you stabilize your hand and you just deviate it a little bit towards your pinky, we call it, it's toward the ulna, correct?
Yeah.
So we call it ulnar deviation. If it was towards the thumb, it's towards the radius. So we call it radius deviation, correct? I realize that there is so many terms. See,
Yeah.
this is why I like to give the introduction, because when I start saying these words, you don't know what they mean. You get lost. You get lost, you become depressed. Become depressed, you will be sad. And if you get sad, you will not study. And if you will not study, you will just sit home, do nothing. And if you will do nothing, nothing will happen. Getting more depression. God. So it's better to know this. Good. So, okay. So this is the rotator cuff. Okay. This area, the shoulder, we call it the rotator cuff. Okay. Our shoulder is an interesting joint. Why? Look at your knee. Try to extend your knee and then flex it. Extend and flex. I love this system because it makes me move. So extend and flex. Extend and flex. You notice that your knee joint can only do one movement, like this or like this, correct? That's it. It's only one side movement, correct?
Yeah.
Okay, good. So let's speak now about your shoulder. Can you move your shoulder up,
Yeah.
down,
Yeah.
forward,
Yeah.
backward,
Yeah.
inward,
Inward. Yeah.
outward?
Yeah.
Yeah. So it's basically a broad movement joint, okay? It has much more because basically it's just a ball and a socket type of joint, right? Like this is the scapula and this is the humerus head. Thus, it has a wide range of motion. Do you know which other joint in the body has the exact same basically wide range of motion because it's a ball and socket?
No.
The femur. The femur. It's the only other bone that has this, okay?
Yeah.
Okay, good. The thigh. So now we'll speak about the rotator cuff muscles. So, okay, we learned abduction, adduction, internal, external rotation. We spoke about all of these different motions. So now it's time to know which muscle causes them. Before I say that, I'm going to go back and speak about more anatomy. This class is not about covering material. This class is just a general introduction, okay? So if you take a look at the scapula of a patient, the scapula has two sides. It has this posterior side and this anterior side, okay?
Yeah.
I really don't care about any of this structure except this. This is called the spine of the scapula, okay? Anything under it, we call it under the spine. So inferior, infra, spine, spinos, infraspinous fossa. And here we have supraspinous fossa. Make sense? Okay, so we have supraspinous fossa, infraspinous fossa. Superior, which means above, spine, spinos, fossa. Fossa means like a fossa. In English, in Russian, it's called yamka. But in English, basically, fossa means, you know when you walk on the street and there is a bit, I mean like a place that has collected a lot of water in it?
Yeah.
Yeah, so this we call fossa, okay? So you can see the fossa on the ground that is full with water, right? This is a fossa. It's big. Okay, so you can see here fossa, and if you look from the inside of the scapula, you are able to see something called the subscapularis fossa, okay? The other side. So this is the subscapularis fossa. In the scapula as well, there is something called the cricoid process, the acromion, not so important. And you have the superior angle, the inferior angle, superior border, inferior lateral border, not important. But what I want you to take home with you is the glenoid fossa. There is something here called the glenoid fossa. So we learned about four fossas: supraspinatus, infraspinatus, subscapularis fossa, and the glenoid fossa. There is a clinical significance for that. The glenoid fossa clinical significance is the fact that the humerus comes here, correct? Okay. The other ones we will learn when we reach them. So far, so good?
Yeah.
Okay. So let's take a look here. They write shoulder muscles that form the rotator cuff include. So the rotator cuff is everything that helps you to move your shoulder. The first one is going to be the supraspinatus muscle. You are like, but you told me about the supraspinatus fossa, correct? So the supraspinatus muscle logically will come and originate from the supraspinatus fossa, correct? So they write supraspinatus is going to be abducting. It comes from the supraspinatus fossa backward, and then it comes here and binds to the greater tubercle of the humerus. Okay? So they write, imagine this is contracting, right?
Yeah.
So it's going to pull to this side, correct?
Yeah.
So what is going to happen to the humerus is going to this side, right? So you have just what you have done, abducted, correct?
Yeah.
Make sense? Okay, so the supraspinatus abduct the arm initially before the action of the deltoid take place. Because the supraspinatus don't cover a lot of surface area, it's not going to abduct all the way. It's going to abduct, but not all the way. So how much exactly? From 0 until 15%. What does that even mean? So if this is 0, he's able to move your arm until here, but that's it. Okay? Okay, so now you understand something about the supraspinatus muscle. So supraspinatus muscle originated from the supraspinatus fossa and is supplied by the suprascapularis nerve. I will make it easy for you. The suprascapularis nerve supplies both the supra and infraspinatus muscles. Okay? Okay. So let's take a look here. Okay, you can see the supraspinatus muscle. When it contracts, it's going to abduct the humerus, correct?
Mm-hmm.
Okay, good. So you can see next, they write here, suprascapular nerve supplies it and hit the right. Most common rotator cuff injury to this guy, trauma or degeneration and impingement. So that can lead to a tendinopathy or tear of this guy. As you can see here, there is a tear of the tendon. And the white stuff basically is the tendon. So it should not be there, it should be here, and it's not here, so that means that there is a rupture, correct? And it's assessed by something called the empty and the full can test. I like to show this test. It's an actual test that we do. Basically, you tell the patient, imagine that there is a can inside of your hand, and now we try to empty it, like just to flip it over to empty it, you know? And well, this will tell us if his movement is, if his rotator cuff movement is working or not, right? Look, so you make him first of all put his hand like this. Now tell him, imagine that there is a cup, and now you want to empty it, right? So they rotate over, and this is the function of the rotator cuff, correct? One of the main guys there is the supraspinatus. Make sense?
Yeah.
Okay, good. Okay, so the infraspinatus muscle externally rotates the arms and yeah, bitching injury. You know what is bitching injury?
No.
Do you know this baseball? Do you know baseball?
Yep.
Okay, good. So we'll show you what is bitching. It's not what my ex used to do. It's different. So this thing, okay? So these people just like overextend their arm and boom, and they might harm themselves, correct?
Yeah.
So that's what is bitching injury all about. So bitching injury, infraspinatus, so it must originate from the infraspinatus fossa, correct? And they are going to bind just right here under the supraspinatus. So they are responsible for the externally rotating the arm, which is like a clock-like movement. Like oh my God, where is the pen? A clock-like movement like this, correct? Okay, so that's the infraspinatus. So basically, it helps us to move our arm like this, but now it's the patient is unable to do so after the injury, correct? Yep. The teres minor muscle is responsible for adduction and externally rotating the arm. So you are like, but no, you told us a different muscle was responsible for the adduction of the arm. What was it?
Adduction of the arm.
Yes, the other one that I told you about.
The teres minor.
The other one, the teres minor is the one that we are...
Supraspinatus.
Supraspinatus, right? Yep. So the supraspinatus used to abduct, but as you can see, it was only from 0 to 15%, correct? So there must be other muscles that can help with that. So one of these many muscles is going to be the teres minor. Teres minor and the deltoid muscle, both of them are supplied by the axillary nerve. I truly cannot emphasize enough how important it is to know that the deltoid is supplied by the axillary nerve, okay? The last one is going to be the subscapularis muscle. So subscapularis, it must have originated from the subscapularis fossa, correct?
Yeah.
So this is going to originate from here and it's going to bind to here. Really important one. Why? Oh my God, I just made a mistake. I'm really sorry. The teres minor is not for abducting the basically the shoulder. It's for adducting. The mistake that everybody makes, I made it. I tell everybody to be careful from it, but I made it. So, okay. So, oh my God, that's embarrassing. So here we have the supraspinatus. I said about abduction, okay? The deltoid is also abduction, but the teres minor is a deduction, which means bullet inward. I was just looking at it now, and I was like, how the hell this is going to abduct? It looks like it's going to bull inward, right?
Yeah.
So the teres minor is going to adduct, not abduct, correct?
Yeah.
The subscapularis, upper and lower subscapularis nerve, they are going to internally rotate and abduct the arm. So they internally rotate, so internal rotation. It's the opposite of infraspinatus, which did external rotation, correct? So infraspinatus, external rotation, subscapularis, internal rotation. And also it helps in adduction of the arm, as well as the teres minor. So they are innervated primarily by the C5 and the C6. I mean all of them, okay? So arm abduction. So from 0 to 15 degrees, of course, we are speaking, this is 0 degrees, this is 90 degrees, correct?
Yeah.
So 0 to 15 degrees, this is going to be the supraspinatus, and the nerve is going to be the suprascapularis, correct? From 15 until 90 degrees, this is going to be the deltoid, and for the deltoid, it's supplied by the axillary. Do you remember the other muscles supplied by the axillary?
The other muscle supplied by the axillary.
Yep,
No.
it was the teres minor, right?
Yeah. Yeah.
And what was the function of teres minor?
Adduct.
Adduction, absolutely. Okay, good. So the deltoid is going to basically move from here to here, but that's it for him. The trapezius and the serratus anterior keep going. Got it? So the mnemonic is salt. So what is salt? Salt is the names of basically different nerves, but the salt should be with double A. Okay?
So would be what?
I will tell you. Salt is serratus anterior long thoracic. So SALT, this is salt. But I personally use another salt. So I say CAALT. Okay? So this is going to be suprascapularis, axillary, accessory, and long thoracic. Okay? So these are the ones that are going to supply from 0 degrees until 90 degrees and more. Okay? Okay. So I know it's a lot of memorization. It's just it's bad, I know. But you have to know it. Basically, this memorization will take you a long way. Okay, so let's speak a little bit about the axillary nerve. What is the clinical significance we spoke about regarding this nerve so far?
Axillary nerve is innervate for the deltoid and the teres minor.
That's correct. Yep. So basically, the way we can destroy it or injure it is by a fracture to the humerus neck. Okay. And also in case of anterior dislocation of the humerus. Do you think dislocation of the humerus is common?
Yep, I think so.
It's really common. Do you know what is the most common place to get the dislocation? Nightclubs.
Playing, yeah.
Nightclubs.
Nightclubs.
I'm not kidding. You know why?
Yeah.
You know the bull?
What?
The bull, like this long bull. I will show you. There is something called the bull dance. And there is this bull, this thing. Yep, this thing. You know what that is?
Yep. Yeah.
So some unexperienced person be like, huh, bull, cool. Let me grab it while I'm drunk. So they do this and they dislocate their shoulder. They come to you. It's pretty interesting. I will teach you how to correct it. I mean, after they dislocate it, you can correct it. But you know what is messed up? If you dislocate it the first time, no problem. You will get it back into the place Absolutely no problem. Dislocated one more time. Oops. The third time of dislocation, it will be so easy. But the fourth time, the arm is going to be dislocated on a handshake. Okay? So it becomes worse and worse and worse. So please try not to dislocate your arm. Okay, so let's take a look. I know it because I literally had a patient who dislocated his arm this way. He was drunk basically, and he just grabbed this spool, moved along, and he dropped, and he just boom, yeah, kind of messed up injury. So fractured surgical neck of the humerus or anterior dislocation, both of these can lead to axillary trauma. So if the axillary nerve is gone, as you said, it normally supplies which two muscles?
Deltoid and teres.
Excellent.
Minor.
Yes. The main one, however, is the deltoid. So the deltoid is going to be flat because he cannot contract, correct? Also, you cannot abduct more than 15 degrees. Why? Because 15 till 90 degrees is mediated by the deltoid, correct? And you will lose the sensation over the deltoid and the lateral arm because the axillary does that as well, correct? All make sense?
Yeah.
Okay, so basically there is many nerves that you have to memorize. Basically, it's a whole list here. I highly advise you because I know that I will speak about them, but you will forget them. So I highly recommend that each day you take 2 nerves and master them. Only 2 per day, okay? This way, they are going just to become common sense. And I highly suggest that you do the movement while you are speaking about them, so it becomes a second nature for you to understand what is abduction, adduction, and all of these things. Okay, so musculocutaneous nerve. It's a musculo and a cutaneous. Musculo and a cutaneous. So it has a musculo branch and it has a cutaneous branch, correct?
Yeah.
So it happens after an upper trunk compression. What does that mean? Basically, there is something called the brachial plexus, which is this thing. It's in our neck. It's basically our spinal cord is here, okay? And out of it, we have many nerves that comes out. But some of these nerves are important, and they are going to basically lead to some basically branches. One of them was the axillary, which we saw what it does. However, now we are going to speak about the musculoskeletal, which is originate from the upper trunk, correct? How do I know that? Well, there is a mnemonic called Hola Latino Med, correct? Latino Med Hola, right?
How do you write the hola?
Hola. You know what hola means? Hola means hi in Spanish. And Latino, it's like Latino. You know who's Latino? People live in Latin America, right?
Yeah.
Who speaks what? Spanish. So hola Latino. Med, because we are doing medicine. So hola Latino med. So that will be upper lateral musculocutaneous, ULM. Got it?
Yeah.
Latino med hola, lower medial ulnar. Got it? Okay, so this way you can know that from the superior trunk, the musculocutaneous comes from. So when the musculocutaneous is messed up, this guy normally supplies the biceps. So the biceps will be gone. So the reflexes over the biceps are going to be gone. So the biceps innervation comes from C5, C6. If I was you, don't worry about this. I will teach all of them for you a little bit later, okay? I mean, which C gives what? There is basically a mnemonic for that. So they will also have a loss of the forearm flexion and supination. Really common question in the USMLE. They show you an MRI of biceps tendon rupture, okay? So MRI, yeah, this thing. So anytime you see this MRI, you see the white, it means there is rupture, and they tell you that, oh, he had some form of rupture. And when you see this, they ask you which function is lost. And you are like, oh, flexion. Let me find the flexion. Okay, let me see. Shit, that answer choice does not have a flexion. So what is it? The other one. The answer is supination. Okay? So how to memorize that in a good way? You know when you are in the gym and you are training your biceps?
Yeah.
You raise the weight and if you want to get one more kick, you want to feel even better about it, just supinate your arm a little bit. You will feel it more. Okay? So now you know. Loss of sensation over the radial and the dorsal forearm. How come? Because of the cutaneous branch. Got it? So let's take a look exactly where it is. So as you can see, this is the musculocutaneous area. Got it? Okay, and that was the axillary area. Now let's speak about the radial. The radial comes from C5 to T1. Again, don't worry so much about the nerve's origination. We'll speak about it later. So it can happen by compression of the axilla. The axilla is not axillary nerve. An axilla is anatomical area. Axilla means armpit. You know what is an armpit?
Yeah.
Yep. So it's an armpit. So how the hell I can compress my axilla? It does not make sense. I will tell you. Radial injury, it most commonly happens in people who are drunk. Yep. So we call it Saturday night palsy. Basically somebody who's drunk, he gets drunk on the chair and sleeps on the chair. Got it? When he's sleeping on the chair, his arm is like this. Got it? So he's compressing his axilla. And that is going to lead to radial nerve injury because it goes through our axilla. Correct?
Yeah.
Okay. So here you go. Okay, so compression of the axilla due to also crutches. You know what is a crutches? You know, for these people who like
for the broken arm.
Exactly, legs. So somebody who broke his legs use crutches, and you know they go under the armpit, which also can lead to this injury. Correct? So mid-shaft fracture of the humerus can lead to that. You are like, always be careful about the humerus because different areas lead to different injuries. So we spoke about surgical neck fracture of the humerus that led to axillary injury. Okay? Mid-shaft fracture is going to be the radius. Okay? Radial nerve. So mid-shaft fracture of the humerus or repetitive pronation and supination. Pronation and supination. Like somebody who constantly work with screwdrivers. Okay? So injuries above the elbow will have loss of sensation over posterior arm and forearm and dorsal hand. But they are trying to tell you that the radial nerve like to supply the dorsal portion of our arm and forearm and hand. Correct? So there is going to be loss of all of the extension movement, which is happening all from the muscles located at the backward of our arm, forearm, and hand. Correct? So loss of elbow, wrist, and finger extension with decreased grip strength. So there will be wrist extension is going to be necessary for a maximal action of the flexors. Let me explain. Our grip is not going to be as strong. Why? Because the extension of our wrist plays a part in making the flexion movement much more potent, much more stronger. Okay? Why? Because when you flex, you totally make the extension absent, correct? However, when you flex your arm, your forearm should extend a little bit to make your grip stronger on something, okay? So it's necessary for maximal action of the flexors. Injury below the elbow causes distal paresis without wrist drop. So what they are trying to say that distal injury in case of the radial nerve are going to be less severe. So there is going to be only loss of sensation without loss of movement, correct? So triceps function and posterior arm sensation are spared in case of the midshaft fracture. So this is actually interesting. So now when you have destroyed the midshaft fracture of the humerus, the branch that supplies the triceps is going to be spared, okay? Which means you can still extend your arm, right?
Sorry.
Bless you. You can still extend your arm, right?
Yeah.
Okay, good. Okay, so that's it for this session. I know it's not long, but what can we do? It is what it is. And we'll continue in the evening. Remember, we have a group class in half an hour.
Yeah.
Okay, see you then.
Okay, thank you. See you.
Bye-bye.